Hey everybody, John Marshall for Medscape WebMD. ASCO 2020, what do you know about that? It was the most efficient ASCO ever. I actually wore pants, you'll be glad to know, as I watched all of the different talks, downloaded some, scrolled through some fast, watched others a couple of times, which was quite good. My feet did not hurt. I didn't stay up too late. I didn't have to get up too early. And sure, I missed a lot, but I also got different things out of this format than I did before. So I don't know about you, but on some level, I kind of liked this. But you got to know I'm going back to Chicago next year if we're allowed. But I wanted to really emphasize all the cool stuff that happened in GI cancers this year. There was a lot of important, what I would call practice-changing data that was brought out. And there's no way to cover it in one of these blogs, but I do think you got to look out for an update or a review, and there's several that are being put together. We are putting one together ourselves. So stay out on the lookout so you can see the detail of that. But I want to touch on some big picture themes that really were starting to hit home in GI cancer. And the first, if you haven't noticed this wave, is that we are all about neoadjuvant chemotherapy now in GI cancers. So if you look at pancreas cancer, if you look at colorectal cancer, and if you look at gastric cancer, you're seeing this increasing trend of induction neoadjuvant systemic therapy. Pancreas, sure, we're talking about FOLFIRINOX, but there was a study that looked at gemabraxane that basically said it played just as well in the neoadjuvant space for patients. So we got choices there. In the gastric space, we've got FLOT, but we're starting to add drugs to FLOT, such as HER2 targeting and the like. In colorectal, there was a nice study looking at FOLFIRINOX again in rectal cancers that showed a very nice path CR rate and some progress there. So it becomes a pretty nice model for us to test. And if you couple that with the IDEA study, which also showed some follow-up data of really no difference in overall survival in 3 versus 6 months, except for maybe a small subset and only a little bit in that one. If you talk about giving like your few months of chemotherapy before surgery, then surgery becomes the last thing you do. Even though some studies can't help but pile on more chemotherapy, my feeling is that what we're seeing is that it's all going to be about neoadjuvant treatment, then radiation in some cases, and then surgery, and then they're done with all their treatment and they can go on with things. And actually, in some ways, this is going to be a quicker readout because we're going to have path CR rates, we're going to have tissue responses as part of our endpoints, and I think trials can be smaller and faster, as we saw a lot of here at this ASCO. So look out for neoadjuvant treatment in resectable GI cancers. The second big area is new targets. Of course, BRAF is one of the big stories in colon cancer, thanks to Scott Kopetz and others who have participated in those studies. And so that overall survival data was published, and I think we have doublet therapy for BRAF V600E mutations. We're piling on HER2. We're seeing more and more new agents coming to the table with HER2. And one of the cool, really new drugs is this TDXD, approved in breast cancer already, now getting tested in gastric and colorectal cancer with some very nice response rates in HER2 positive colorectal, HER2 positive gastric cancer. And then, of course, last but not least is IO therapy. We made plenary session this year with a paper looking at frontline pembrolizumab versus chemotherapy. Fascinating curves where the pembro actually didn't perform as well initially compared to chemo, but the tail on that curve for pembro trumps by far whatever could be done with the chemo arm. And of course, there'll be crossover in this study, so it'll mess with the overall survival. So it really suggests in the MSI high colon cancer, metastatic colon cancer, single agent IO is certainly in play, with a lot of discussion of maybe we should be doing chemo plus IO as induction chemotherapy. So stay tuned for that. But my guess is we will have approval to do frontline IO in MSI high colon cancer. Whether this applies to the other GI cancers is yet to be determined, and the biomarkers are not the same across all of that. The story in liver cancer is IO. It's off to getting, seems like cured IGO. They just keep doing better and better with frontline IO approaches in liver cancer. There's doublet in gallbladder cancer that looked very promising in frontline. So a lot of new treatments. IO is here to stay. Biomarkers were coming forward. New targets are being identified, therapies identified for those, and neoadjuvant therapy for a shorter period of time. We'll get to go first as oncologists. The surgeons will get to go second. So I hope you have time to review some of what happened at ASCO across all of the different diseases, but in GI, that's a very high-level summary of the big stuff that happened, in my opinion. John Marshall for Medscape WebMD.